They're kind of like a linear a little bit with pustular. And yeah, potentially there's a history. Sometimes you don't have a history because people don't remember being exposed to the plant. Or sometimes their pet is exposed to the plant, and then they rub the pet and they get it on them that way. And these are annoying rashes because they're very pruritic and they are tough to get rid of. And they're due to this substance called ursochiol, which is in these plants. Don't forget about chemical exposures to metals, like nickel allergy will cause that. Somebody on their belt buckle area will have the allergy, or on their watch. So the location of the rash can give you some clues as well. And allergic rashes can be severe with Erythema multiforme or even Stevens-Johnson, and those require burn care. The Stevens-Johnson case will require to be the burn center. Chemical burns, on the other hand, are going to cause a more burn-like picture, like a thermal burn. And chemical burns can be liquefactive or coagulative. What does that mean? Liquefactive is the chemical digests the tissue as it penetrates deep. So you have deeper and deeper liquefaction of the tissues. An example of that is bases. Bases can do that. Acids, on the other hand, they cause a coagulative burn because as they contact the skin, they cause a coagulum. And the coagulum crusts it off and kind of stops the deep penetration of the liquid. Okay? So acid versus base, coagulative versus liquefactive. Bases are usually deeper in their reach than acids. Now, we think of chemical burns from acids and bases, but that's not the only way you can burn the skin with a chemical. Think about sulfur mustard, think about lewisite, phosgene oxime, particularly sulfur mustard and lewisite. They are not acids or bases. That's not how they cause the damage. And I shared with you yesterday some of the mechanisms that the way they do it. For those of you who did not attend the lecture yesterday, current understanding of lewisite mechanism of action involves genetic changes, so genetic expression changes from the lewisite that lead to the unfolding of proteins, and the unfolding of proteins causes the clinical manifestations. And the way you stop that is potentially by preventing the unfolding of the proteins. And there are some countermeasures that are being developed to do that, but an old countermeasure is cold water. This is why when you burn yourself, you put your hand on the cold water, the cold temperature prevents the unfolding of proteins. That's why it works sometimes, limiting the size of the burn when you stick your hand under cold water. So vesicants, again, like sulfur mustard and lewisite, are going to cause burns, and they're not acids or bases. And the burns from chemicals usually are immediate. Okay, usually they're immediate. The delay in the onset is not typically a chemical burn. Okay? Radiation, on the other hand, is a classic example of a delayed onset burn. So anytime you have a delayed onset burn, think radiation. Most of these chemical burns are local in their effect, although some have systemic complications. Classic example is what? Hydrofluoric acid. Causes a chemical burn and it causes systemic effects. We also have special cases that we know as toxicologists. A yellow burn. A yellow burn. What causes a yellow burn? Which acid? Nitric acid. So, white phosphorus is a special case. I mean, we have some special chemicals too that we need to know about. This is the guy I had in Grady. This is a sulfuric acid battery. So he, I don't know, messing around with the battery, splashed him with sulfuric acid. And the reason why I show you this is you see the crust. I don't know if you can see it. See the crust on his forehead? This is the best example I could find of coagulative necrosis. That's a close-up. And you see it looks like a thermal burn. Right? What's the difference between this and a partial thickness burn? But the history here is important. And of course, you have to look at the eyes, because the eyes can also be affected. And you have to irrigate those eyes when this happens. And this is the guy that he did well, and that burn on his forehead is really managed like a thermal burn. There's nothing else you gotta do. So we don't do much toxicologists with this, you know. You don't need a toxicologist for this case. All you need from me is to like tell you that what is the pH maybe, or what is, they call us to find out what the chemical is because we have the resources, we can look it up online. This, on the other hand, is a deep liquefactive burn. This is a patient of Dr. Morgan when he was in Charlotte, North Carolina. And you see how the beefy red liquefied burn on her face. Now, on the other hand, hydrofluoric acid, as we said, is going to cause systemic effects. It's not a great acid in terms of the burn itself. I mean, the burn itself is not that bad. But the pain is very severe. Why is there so much pain, Ala? It goes to the bone. It's in the bone. So fluoride ion is small, so it penetrates. The acid is not the main issue in hydrofluoric acid. It's the fluoride and the bone causes hypocalcemia, as you said, and hypomagnesemia. And then you complicate the whole picture with hyperkalemia. And hyperkalemia leads to the cardiac arrest. And of course, hypocalcemia can lead to torsade de pointe. Torsade de pointe or polymorphic ventricular tachycardia. And the management is what? Calcium, 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 depending on the severity of the lesion, of course, and the route. You know, you can pick intradermal, intraarterial, intravenous, depending on the severity. Topical, on the eye, by nebulizer. It really depends on how severe the case is. I've never seen a very severe hydrofluoric acid case. The ones I've seen were more from low concentration hydrofluoric acid in the 10%, 15%. And they typically have pain. And the way I manage those is by either topical, if I can get away with it, but it's hard to get away with it. Most of the time, they keep having pain and they don't feel better. So you have to do the intraarterial calcium gluconate. If you have finger burns, it works really well because you insert an arterial line, and like you see here earlier, and then you intraarterial line, and you give calcium gluconate. Don't give calcium chloride intraarterially, calcium gluconate. And they do really well with that. And the last case I had a few years ago, the guy came twice to the ER, and I felt bad. I was like, okay, I'm done with this. I'm going to just put the arterial line, because we tried to do the topical stuff. We put some topical, we sent him home, he came back the next day still feeling bad, and we put more topical, taught him how to do it better, and he still came back the next day, and finally we did the intraarterial. Yes. Yes. And also remember, the hydrofluoric acid may be under the nails. And who wants to pull nails? Do you really want to pull the nails? I pass out if I'm pulling a nail. But you have to, you start wondering, do I need to pull the nails? And so that's why intraarterial is better. But, we had to admit him to the ICU for this intraarterial. I tried to put him in the observation area, but they refused. So I had to put him in an ICU for this. So I was trying to avoid this whole process, but eventually that's what I needed to do. No, so that's a great question. So Bara is asking what's the difference between calcium gluconate and calcium chloride. Calcium chloride per ampoule gives three times as much calcium per ampoule as calcium gluconate. So if you have crashing patients who you need to give calcium quickly, by amp, give chloride. But chloride, if it extravasates, it causes tissue necrosis. So you must have a nice IV, 18 gauge anticubital fossa, probably placed IV, and you can give it, or central line even better. Calcium gluconate you can give intradermally, if it extravasates, it doesn't cause any problems, but it has less calcium per ampoule. And calcium gluconate you can give intraarterially as well, not calcium chloride. Okay? So moving along to the other types of burns, let's think about some of these blister-forming chemicals. The king of that is what? Sulfur mustard, the king of World War I, causing the largest number of injuries in World War I from the chemicals is mustard, more than chlorine. The issue with sulfur mustard, though, is that it has a relationship with ambient temperature. So first of all, if it's hot, like it was in Iran and Iraq war, it can evaporate and cause more pulmonary effects than it did in Europe in World War I, where the temperatures were colder. It also has a freezing point that makes it vulnerable when in low temperature environments. So you cannot really use it through aerial dispersal or aerial bombing in the cold environment. So that's why they added to it other chemicals such as lewisite. Okay, that's why, for example, the Japanese added lewisite to it when they were using it against China. The good news about it is the mortality is not very high. It's about 5%, 3 to 5%. But the bad news is that patients are going to be sick for a couple of weeks, 2 weeks to 4 weeks, and then that means they're going to be occupying a hospital bed. They're going to be requiring care by a nurse, by a physician, and they will not be able to fight for that period. The toxidrome of a vesicant is, of course, the skin blister, but also the eyes and the lungs. They don't all have to come together. A few years ago, or maybe either 1 year ago or 2 years ago, I got a call from a colleague in the Republic of Georgia. He actually sent me he called me at like 4 in the morning. And I was like, why is he calling me at 4 in the morning? I was awake though because I was going to a race. I wasn't racing. I'm not that fit. I was going to a medical tent for the race. It was July 4th. We have a race in Atlanta on July 4th. Then he sent me a message on Viber. He says, hey, can you send me some stuff about sulfur mustard? I was like, why is this guy asking me about sulfur mustard at 4 in the morning? So I called him. I was like, what's going on, man? He's like, we have sulfur mustard cases in Tbilisi. I was like, what? It was workers at an airport that saw a leakage of liquid in their kiosk. They have a travel agency kiosk. And I don't know, somebody maybe touched something. We didn't have all the history. But this doctor had in his ER 2 patients, and then the 3rd patient was at another ER. And then, of course, a total of 11 patients presented by the end of this process. They were not injured, but they were concerned, so they came in to be checked out. And those patients that he had this very small pimple on his arm, very small, like less than half a centimeter in diameter. The other guy that was in the other hospital had a bigger lesion, bigger pimple. And it's interesting, they were exposed the day before. So this thing happened on, so July 4th was when he called me at 4 in the morning, which was afternoon in Tbilisi. These guys were exposed the day before on July 3rd. Okay? And they didn't develop symptoms till several hours later. One of them developed some eye burning. Okay, some eye burn, like conjunctivitis. Then he developed the pimple. None of them had respiratory effects. Probably because the amount was very small, and which is reflected in the size of the blister. You know, the larger the blister, the more likely you had a large exposure that's probably causing respiratory effects. Typical symptoms. And I said to him, this is sulfur mustard, classic. And he had found out because actually they found the bottle and it said on it Ipperite. And he's like, what is Ipperite? I said, Ipperite is Ypres in Belgium, the first place where the chemical weapons were used in Belgium. And that's why they call it Ipperite. Anyway, so that's the long story short. They did okay. Those 2 patients did okay. They had a classic progression of their lesion into the rash. And in a little bit, I'm going to ask Dr. Ala Mohsen and other Iraqi colleagues, Dr. Hammoudi, to talk a little bit about their experience in Iraq. And we have some slides from Dr. Ala Mohsen who shared them with me that will show them. But this is interesting about the mustard, the progression. Now, lewisite was made to cause more immediate effects. Okay, but we don't have a lot of experience in lewisite, unfortunately. Well, fortunately and unfortunately, because it was really never used in a battlefield, but it was more in the lab when we have a couple of case reports. But look at these blisters, how they are, again, like a thermal burn. You know, this could be a thermal burn. This could be a chemical burn, like an acid or a base. And eventually, as they heal, they have changes in the pigmentation. They can be hypopigmented, hyperpigmented. These are pictures from the board and textbook of military medicine of Iranian, most of these are Iranian casualties. Now, this is from Ala. Ala, you want to share with us a little bit? Can you come up here? So they can hear you well. Do we have a microphone, please, for the, you have a microphone, like handheld? Or you can just go up to the, go. Tell us about this guy.
This guy, this is one of several people who came to the ER, but this was on the field.
Yeah.
Okay. Anyway, good morning.
Dr. Ala Mohsen is an emergency physician and CBRN expert from Iraq. He's currently in Muscat.
Thank you. You have the other pictures or just this?
Maybe one more.
We have several cases coming to the ER in Baghdad Teaching Hospital. We have several events of mustard chemical exposure in the war against ISIS from 2014 to 2018. This is one of the people who was decontaminated at the field. And you can see two sides of blisters on his shoulders. He carried an object which is
leaking.
It was contaminated with mustard particles or mustard
liquid
debris. And immediately, this is the second day, I think, because you can see he was, I think he was a civil defense officer.
And remember, it goes through the clothes. It can penetrate through clothes. So he could have been wearing something and still the liquid seeped through the clothes.
We found typical, the first presentation was that they all had respiratory problems, especially the people in, I think Dr. Hussein had more experience in that in Taza, because he went in the field at that time. The first event was in Taza, 2014. And then after that, several attacks appeared in different parts of Iraq, especially in Mosul. Typically, they start with respiratory problems after inhalation of the yellow gas. Sometimes it was with chlorine gas, not just mustard. They use two types of missiles. But they present with respiratory problems, mucosal irritation, conjunctivitis, red eyes, secretion, and then second, third day, sometimes to the fourth day, blisters start to appear. That's when actually we diagnosed it was mustard gas after the blisters appeared. Because at the beginning, because several times they used chlorine. It was suspicious of chlorine. But in Taza event, blisters start to form. And then the mustard was diagnosed as the first time. Then several attacks appeared using mustard gas.
There's another picture.
Yeah, these were in the ER in Baghdad Teaching Hospital. They had several attacks. They were admitted in burn center, burn unit hospital, and they treated as burns. Only one had respiratory complication from, I think, 14 to 17 patients we had. He developed pneumothorax. I think a blister inside the lung bursted and made a complication of pneumothorax. So, some of them had eye problems, referred to ophthalmology. Dr. Hussein gave a trial of the N-acetylcysteine, but most of them were treated conservatively. The only death was a child, which was from the event of Taza. She was very little, had comorbidities. Child, I think 6 years old. I had the pictures for her. That's the only death from mustard we had.
Good. Thank you.
Thank you.
We checked for bone marrow suppression. If you have significant exposure, the bone marrow is suppressed because remember, sulfur mustard can cause that. And usually it follows the same type of nadir and recovery that you see in radiation injuries. So this is why there's a similarity between sulfur mustard and the radiation exposure. So if you have a blister from a radiation exposure, you may think it's a sulfur mustard exposure because both of them will cause bone marrow suppression. So be careful with this. But however, the mustard will cause the conjunctivitis and the pulmonary effect, potentially, which you do not see in radiation exposure. Okay, so that's how you gotta differentiate between the two when you take your history or do your physical examination. These are some pictures of the long-term healings of these mustard. Like I said, lewisite was made for its immediate effect, immediate action, and immediate effect, but was never used. Now, I wanna clarify one thing that I may have not said clearly. Sulfur mustard action on the cellular level is immediate, within minutes, but the clinical manifestations are delayed. Remember that, because often if you show up to the ER after sulfur mustard exposure, it's too late to decontaminate. Okay, because already the mustard is entered the body and causes damage. So, and the blisters do not contain mustard. That's another common misconception, that the blister is full of mustard. No, there's no mustard inside. Okay, that's another important thing to remember. Lewisite also acts immediately, and the clinical effects are within minutes. That's important to remember. And we don't have a lot of experience with it, because really we have no use in the battlefield. There's one exposure in a China construction site to mustard lewisite combination that led to one death and several dozen exposures. But we don't have like more experience like we do with mustard. But Dr. Kosnet, who's a colleague of ours from ACMT, past president of ACMT, he shared with me when he did a grand round about this recently, some pictures of lewisite that is in the lab or in a case report. You see similar blister to what would the mustard be. Apologize for the quality of these pictures, but that's all we have. These are really old reports. And you see here also the rapid onset. Within 2.5 minutes, you know, look at the progression, 15, 30 minutes, 12 hours, 24 hours. And it took a couple of weeks for them to heal off. This is not the case report that he was able to find. I think Dr. Kosnet had to go to the library or something to pull this case. And you see the severe burn in the leg, about 25% burn surface area. This required a skin graft after the patient was treated for the acute illness that he had from it. Finally, in the chemical world, we have to think about white phosphorus. White phosphorus is very interesting because it's actually going to cause three things. So in your toxidrome, you are going to appreciate three things. One is a thermal burn, because it ignites easily. It's going to cause a chemical burn because it becomes phosphoric acid as it hydrolyzes. And the third thing is going to cause systemic effects because it's absorbed, and it's going to cause hypocalcemia. And on top of that, it's also going to cause a phosphorescent light and smokiness of the wound because of the burn and the reaction with the tissues. You can see some smoke coming off of it. And I'll show you some pictures here. This is, I've never seen a white phosphorus case, but I was consulted on the phone on somebody who died. There was an industrial engineer in Sacramento, and he was exposed to white phosphorus, and he had an airway compromise, and he died basically. This is a soldier who was exposed to white phosphorus in training. You see the phosphorescence on the right under the UV light. And you see the burn there in his head. You see the signs of a chemical burn and a thermal burn. Of course, the picture on the left is much more severe airway injury. I also used to have a picture where you can see a little bit of smoke coming off, but I don't have it here, I think. Oh, here it is, yeah. You see a little bit of the smoke where the arrow is. It's really hard to see smoke on a photographic still, but you can see a little bit coming off. Finally, radiation. Radiation, again, is always going to be the one that you want to not miss because it is not going to have a lot of overt signs initially. So if someone is exposed to radiation by handling a radioactive source or being close to a radioactive source, they will not have any effects in the several hours, maybe days or weeks, until they develop the skin burn. So they will forget what they were exposed to, and you have to really do a good history and take them back several weeks to try to see if they actually potentially were exposed to radiation. Usually these radioactive sources are unshielded, okay, so they are removed from the container that shields the radiation. Typically this happens accidentally or maliciously, okay? And these radioactive sources are going to be emitting gamma rays. Gamma rays can travel hundreds of yards, depending on the activity of the source that's emitting them, and they can penetrate through the whole body. And so it's really hard to shield from gamma rays unless you use, lead or steel to try to shield the environment from their effect. This is on the right. This person is an Iranian worker who was working at a plant and found a radiation source. He didn't know what it was. He placed it in his side pocket for a few hours, and then removed it. And then he started, over several days later, developing erythema, which is the first phase that you see. And of course, it's dose dependent. The higher the dose of radiation you receive, you can start with erythema, or you can get blisters. These are patients from Goiânia, Brazil, that were actually handling in their hands cesium-137, which also emits gamma rays and beta particles. And again, I'd like you to appreciate that this looks like a thermal burn, right? This looks like the patient I showed you at the beginning from Grady. This is why you need to ask these questions. And this is weeks later. This doesn't happen immediately. This is not going to be the first day, not the first week, sometimes the second week when you start seeing these effects. Whether you see moist desquamation or dry desquamation, or necrosis. So that's the one cause that is going to trick us, because it's delayed, it's so delayed. So in summary, what did we learn? We learned that burns and rashes are common in our emergency departments. We have to maintain a broad differential when we look at them. We have to think of the biological causes. We learned how to think through the viruses, the bacteria, some typical patterns that they cause, like Yersinia or tularemia or anthrax. Smallpox is a great example to differentiate from chickenpox. And we talked about the importance of the other symptoms that occur with it, the prodrome, the incubation period, and the challenges like infectivity and transmission, person-to-person transmission. Then we talked about chemicals and thermal burns. We went through a variety of chemicals, acids and bases, and those with special properties like vesicants or hydrofluoric acid and white phosphorus. And finally, we finished off by looking at the one that tricks us every time, which is radiation, because of its delayed onset. But as I said, at the end of the day, you saw how they all can look similar. How anthrax can look like a brown recluse spider bite or an ionizing radiation exposure. How tularemia can look like potentially a chemical burn if it's localized. So I hope you enjoyed this presentation, and the next one is going to be done by Dr. Chuck McKay, and he is going to tackle for us the irritant oxydrome. Any questions before he gets up on the stage? Dr. Barra. The picture for sulfuric acid, yes.
I want to show it for me, please, sir. Yes, the previous one. No, the previous one. There's a tube inside the eye. This is for water irrigation?
Oh, you mean this one?
Yes, this one.
Yeah, so this is, we call this Morgan lens. It's basically a kind of a contact lens made of plastic, soft plastic. You put it inside the end, and the other side you connect it to IV tubing, and you can irrigate, because you have to irrigate the eye with a couple of liters of saline.
Which type fluid?
Saline.
Saline.
But you have to you have to be generous to get the pH of the eye back to 7.
Thank you, sir.
Thank you. All right, Dr. McKay, would you like to walk around with this, or would you like to stand up? You walk around?
Of the American College of Medical Toxicology. He's also the past director of the Connecticut Poison Center, and is academically affiliated with the University of Connecticut, still, until now.
Yes, still, yeah.
And he is one of the leading experts in, I think, hazmat and chemical emergencies in the US, and consults for governmental and non-governmental agencies on this topic. So we're really fortunate to have him today tackle this topic for us.
Thank you, Ziad. All right, so in keeping with the way that Dr. Kazi set this up, we're going to try and keep an idea about the presentations, the clinical presentations, that can help you decide both that there may be shared exposure, so there may be more patients who may become sick if they're not already presenting to you, and then try and sort that out from possible infectious radiation-induced or chemical exposure etiologies, and a little bit of the treatment in there. And I think there's going to be some overlap with what we've already talked about in terms of the skin issues and respiratory, because if you think about it, those are both very large surface area organs to which we expose ourselves every day. Inhalation becomes, I'd say, more important because of its effect on systemic issues, but it is, the skin is said to be the largest organ, right? But if you take the lung out and put the surface area of the alveoli across an open plane, then it's the largest organ. And that's what you're exposing yourself, or patients are exposing themselves to, once they start inhaling. And of course, we have to breathe. So in terms of how the lung or the respiratory system reacts to exposures of any kind, you could think that it's really fairly limited, but some of the problems get to be the words that we use. So dyspnea, as an example, or dyspnea, as you might spell it, it really means difficulty in breathing, but what we usually are talking about are what we see as far as the patients experiencing difficulty or what they describe. And so what we see would be somebody breathing fast or over-breathing. The patients are saying, I can't get enough air, or they're having trouble even completing a sentence as they're trying to tell you their problems. So that's certainly difficulty in breathing. But if you think about it from a physiologic point of view, somebody who's not breathing enough is also having difficulty in breathing because they're not ventilating adequately enough to oxygenate their tissues. So then they would suffer from hypoxia. But hypoxia, again, could be the symptom the patient has of just air hunger. I'm not getting enough air or oxygen. Or it might be the inability of the air to hold oxygen, and that we talked about when you listed the first grouping of syndromes, the simple asphyxiants, you just don't have enough oxygen in the air. Or it could be that you can't pick the oxygen up and carry it around to your tissues because of a hemoglobinopathy, carboxyhemoglobin, methemoglobin, those kind of things. Or it might be a problem that the cells can't use the oxygen once it's delivered, and those are the mitochondrial toxins in terms of chemical effects. Or it may just be that you're outstripping the ability of you to supply the oxygen by the tissue demand, that may be occurring with systemic illnesses. Or maybe you found an infiltrate on an imaging study and you think, well, that person must be having some pulmonary difficulty of some kind or other because they've got white out of their lungs. But is that water in there? Is it inflammatory conditions? Is it actually occupied by tissue? Is it, is this a fibrotic process, or I guess on long term even, is it a cancer? Compressing maybe the airway. So there are all kinds of different things that might be summarized by somebody as a single word, and if we focus on the word, we're going to miss potentially the causes. So try to split this up into these three major areas and just go through some examples in the next 40 minutes or so. So I'll start with radiation because, in a sense, in contrast to the skin issues, radiation is maybe a little bit easier. Radiation exposure and respiratory complaints, you would not expect anybody to show up with a primary respiratory syndrome following an acute radiation exposure. But in terms of dealing with people who have had radiation exposures in the past, it becomes a major issue in terms of impacting a system's ability to deal with them, either from the hospital basis or even from a societal basis. And we see this in small part, in kind of in miniature, with the patients who receive radiation treatment for their cancers. Successfully curing a cancer, but then months to even years later, they may show up with a delayed radiation syndrome that is the outcome of injury that happened months to years earlier, when again you have problems with destroying the cell's abilities to replicate and inducing some fibrosis, which then gets to be an obliterative arteriopathy, and now you end up without being able to adequately support new tissue, and you end up with a fibrotic from the pulmonary aspect, you can end up with fibrosis in a number of different organs, in that sense, anywhere that the radiation field was. But certainly for a whole body radiation exposure, you can end up with complications that include radiation pneumonitis delayed effects, as a delayed effect. Just to mention this as Health Physics. It's a journal I don't read regularly, but they had a whole issue in the spring of 2019 focusing on the spectrum of delayed effects following or of acute radiation exposure, which, if you're interested, is there for you. From a point of view of infectious diseases, again, I'll focus that, somebody coming in who is looking tachypnic, that they're air hunger or that they're having trouble with their breathing, and one of the things we tell all our residents is don't just assume that they're hyperventilating, right? Somebody who's tachypnic has a severe metabolic acidosis with respiratory compensation until you've proved otherwise, because that may be your early warning signs that they are actually undergoing sepsis or other systemic process. And the worst thing to do for them is to assume they're just anxious, and now treat them by not paying attention to their underlying illness. And certainly, if there were this infectious source, you would expect that there would be other symptoms going along with that, perhaps referable to the very nature of where their infection is. Do they have urinary complaints as they're coming in? They should have a fever. But a lot of times you're going to end up with a person who may be somewhat altered because of their underlying infection. They may not be able to provide you all the history that you're looking for, especially in terms of some of the prodromal symptoms. But then, I think as it's mentioned, you want to search for that history, and that may mean getting a hold of family members who are able to provide that. If the patient can't talk to you, perhaps somebody who's been spending some time with them can. And perhaps, since we're talking about clusters of illnesses in terms of clusters of patients presenting, an infectious disease would be less likely to present in that way, because everybody is going to have somewhat different latency period to develop their infection and all. But depending on, again, if you look at a cluster over a short period of time, then you can certainly have infectious diseases responsible for that. We think of the flu epidemic every year is a cluster of illnesses that are spread out across the world over time, but they will tend to be within a particular region over a short period of time, a few months if you're going to look at it that way. And the reason to kind of keep that in mind is that there are some infectious diseases, as Jan mentioned, in terms of, say, bubonic pneumonic plague, that would be potentially transmissible. So you don't want to just assume that the group of people who have this funny looking pneumonia and a few skin lesions and were out on a hunting party together are not related. They may very much be related, and you don't want to ignore them. Important to emphasize that other things that cause very, very prominent pulmonary findings on X-ray, or at least chest X-ray findings, more of a mediastinal widening, which we are taught to be indication of anthrax. That's not a pneumonia, and it's mediastinal lymphadenopathy and hemorrhage, and so that is not something that's transmissible person to person. So it's important to keep those in mind as well. And also chemical exposures can occur that will allow a secondary contamination. It's not really an infectious transmission, but it can cause a secondary contamination. So it's important to keep these in mind. So then we'll move to the chemical exposure, and there are many, many chemicals that will cause respiratory symptoms, but they are not ones that you typically think of in clusters. Would not be usual for somebody or for a group of people coming in after they'd all been poisoned with aspirin. But could that happen? Well, sure, if there was a medication substitution and everybody thought they were getting, Tums, and they were getting an antacid, and they end up getting a salicylate instead, their stomach pains would worsen and they would take more, and I suppose they show up that way, but that would be very unusual. There are a number of medications, though, that certainly can cause tachypnea with or without associated pulmonary injury or pulmonary edema, for example. So salicylates would fit in that. Metformin, will cause a metabolic acidosis, and people will show up then with the respiratory compensation, perhaps as a significant finding. And then there are other medications which, like say topiramate, which actually has activity as a carbonic anhydrase inhibitor. So after an overdose, patient will show up with respiratory symptoms, usually the next day. So a delayed onset of respiratory symptoms. But again, you wouldn't expect those in clusters. So do medications just kind of fall off of your list as far as a differential? Not really, because we've talked over the last few days quite a bit for those that we hear about the opioid issues. And so fentanyl analogs in the drug supply are showing up as clusters of severe respiratory symptoms, usually hypoxia, anoxia, pulmonary edema, related to a shared exposure. And then Dr. Thompson yesterday Trevon was talking about the e-cigarette and vaping associated lung injury that we saw in actually every state in our country last year, mid to end of 2019, that was probably largely associated with a single group of individuals who were sending out these cartridges, which they'd obtained from China, and then filled with homemade liquids, cannabinoid liquids that were over-adulterated with a vegetable oil. And basically people were inhaling grease, although there's some debate as whether that's the full explanation or not, but this one source in Wisconsin ended up having thousands, tens of thousands of cartridges in their home when they were arrested because of, again, awareness. People in the neighborhood had seen a lot of traffic in this area and thought that it was suspicious, so they called police and then found basically a home manufacturing site without any of the controls that you would want for manufacturing drugs. This would be, I guess, another clue that maybe there's a chemical exposure going on to the people that are involved in this. So this is a multi-vehicle crash up in the northern part of our country a couple of years ago where there ended up being several deaths, about 150 vehicles involved, tanker cars. As you can see, obviously, a lot of fire and smoke that was being generated from that. Actually, one of the trucks was carrying fireworks, and so that's why you're seeing these little streamers kind of going up in the air there. So a very explosive situation and with a lot of potential for exposure. But if you're going to go into that, or if responders are going to go into that, they're going to want to know what it is that they're facing and what the patients are going to be experiencing as they come out. So taking a look at the spectrum of chemicals that can be inhaled and then cause some kind of illness, I'm going to focus mostly on the simple asphyxiants and the respiratory irritants, but there are other agents that can cause problems that are inhaled, and I've already talked a little bit about some of these, but things that will induce carboxyhemoglobin. Well, fire is a good source. Chemical asphyxiants, so cyanide, and if you have a fire, you're going to generate cyanide if it's a structure fire or any modern building because of the mixture of plastics and rayon and other kind of material which will liberate cyanide as it's burned. And of course you can inhale not only the particulates cause pulmonary injury, but other systemic toxins as well through the respiratory route. So we've always talked about dose as being the determinant of toxicity. When you're talking about something that's been inhaled, you now have to throw a couple other factors in because it's not just the amount, right, but it's the concentration in the air, which would be the amount, and how much you're breathing in and out, as well as how much of a given inhalation is absorbed or maintains contact with a part of the respiratory tract, and how much is then exhaled. And that kind of speaks to how we would want to treat people who have been exposed to an irritant or a toxin or a toxicant through the inhalation pathway, is if you keep breathing it in and out, then you're going to continue the injury, continue the exposure. So the first tenet of treatment is to get them out of the area of exposure. And while that seems pretty obvious, I'll go through a couple of examples where that just didn't occur to people and caused additional harm because of that. So it's not only, again, just the dose, though, it's also who is inhaling it and the circumstances of their exposure. So if you have somebody who's got underlying lung or heart disease and they're inhaling in a pulmonary toxin, then they're going to have more of an effect than somebody who's otherwise healthy. Or a small child who's going to be inhaling and exhaling more frequently and larger concentrations relative to their body size, they're going to have a greater exposure effect than an adult would. And then the property of the agent becomes very important. So we're going to spend a lot of time looking at the first aspect of water solubility. Right? Water-soluble agents behave completely different than agents that are not very soluble in water. And the reason is because the whole surface of our airway and the areas near our airway, like the eyes, are covered in water. And so that's going to make a big difference in terms of how you present. The pH obviously makes a difference because of a caustic nature, direct injury to the lung or tissues that they make contact with, and volatility. So if somebody is very volatile, then it doesn't have to be a gas to end up in the gaseous phase, right? It will become a gas even though it may have started out as a liquid. And where you're exposed makes a difference. If it's a very dense agent, then you're down in a valley, you're going to be more exposed, or if you were down in a trench, for example. And then particle sizes in terms of where the deposition occurs. So all of these things become important features of what the delivered dose is, and that is, as we mentioned already, what determines toxicity. So I just start with the simple asphyxiants. This is a case that happened just a couple of years ago up in the northwest of our country. This was is an ice cream salesman, so he wants to keep his product cold, and he had dry ice, which is just solid carbon dioxide, but he left it in his car, several cakes of it, and then had his family members sitting in the car. And when he came back out, they were unresponsive and dead because they had been inhaling carbon dioxide, which had displaced the oxygen as the dry ice sublimated and became carbon dioxide. This has actually been used sometimes intentionally as a way of killing other people and leaving no trace. So it's a potential problem in a number of settings, but certainly when this is used inappropriately, an industrial compound basically, used inappropriately, that becomes a problem. And the simple asphyxiants, they're not irritating. People did not become aware that they were in a harmful environment because of irritation. They became aware, if they became aware, because they were experiencing air hunger. They felt like they weren't getting enough oxygen, which is true, they weren't. But the trouble with carbon dioxide is it's also a bit of a narcotic, so it can actually depress your ability to respond before you will appreciate that you need to respond. Treatment, as I already mentioned, is pretty simple. And there's a number of examples of this, of carbon dioxide, nitrogen, methane, the inert gases, which are used in a lot of industries to establish a non-reactive environment, to do very precise metal working, that kind of thing. So helium, argon, xenon, those are all potential sources of a simple asphyxiant exposure. Respiratory irritants, as mentioned, these are the largest group of chemicals. This is just a listing over a number of years of exposures that have happened in the United States where there have been releases, and as unintentional releases to the air, generally air for these compounds. And this, in the first column there is the name of the compound. The second is the number of exposures over this 5 to 6 year period. And in parentheses are the number of deaths that occurred with those accidents or releases. And the areas that I've highlighted are all respiratory irritants. So these are some of the most common agents that we have exposures to in an industrial basis, and then it gives you an idea of the magnitude of those exposures. But we'll go through a few examples of some of those that are on the list. And the ones that, or the way to differentiate them, most importantly, is on this slide. So the things that have high water solubility are going to cause symptoms early, because when you are exposed to it at the mucous membrane of the eye and in the nose and in the throat, you're going to be irritated. They generally have a good warning properties because of that. Sometimes it's just the irritant nature, but often it's also the odor associated with them as well. And they will cause mostly upper airway injury because, or irritation, because you're going to get out of the environment if you can. Now, if you're trapped, or if you're unable to extricate yourself, then you will end up with delayed, or not delayed, on lower airway injury as well, because you'll keep breathing them in and out. But these are often agents that have sufficient warning properties that people will notice them at very low concentrations and then get out, but they're irritated enough they'll come and seek care. But you want to know the people who you need to provide a lot of time and attention to, from those that are just crowding because they're worried, because they've smelled a bad smell, or because their eyes are irritated and running, and not get distracted by the very large number of people that come with very mild symptoms. That's in contrast to those agents that have low water solubility, where people will often continue to breathe them in and out during an exposure, during a fire, during a workplace exposure, or a common source in a large building, for example, because the agents do not dissolve in water very well, and therefore they're not irritating. And if they don't irritate, people won't recognize that they're causing injury or damage, and they'll continue to breathe them in and out. And as they breathe them in and out, they're carried down deeper into the lungs for a longer period of time, multiple breaths, and that will result in injury predominantly to the lower airway, so more pulmonary injury. The clinical marker of somebody with an exposure to high water solubility, if they've had enough time to get some significant exposure, is going to be the inflammatory response at those surfaces. So they'll end up with red eyes, tearing. They'll end up with wheezing because of noisy lungs, because of the response to the bronchospasm, as well as the increased airway water. The hallmark for people who come in with low water solubility exposures is that they've got hypoxic symptoms, because they now are having a progressive inflammatory process in their lungs, which often is presenting with either pulmonary edema or fibrosis, depending on the delay. And they will show up with decreased exercise tolerance, cough potentially, and then findings on auscultation and x-ray. So very different presentations. These are just some examples. So as a school teacher, this is a woman who came in to see me complaining of chest tightness after she'd been cleaning up the classroom. She said that she'd mixed a couple of cleaning agents and scrubbed some desks to get rid of some graffiti that people had put on the desks. And when doing her review of systems, she mentioned that she had some eye irritation. Now, normally when people come in saying to triage, I'm having chest pain while working, people are kind of channeling towards the idea that this is a cardiac complaint. I was working, I got chest pain, sounds cardiac. So she had an EKG, she had a pulse oximeter, she had her vitals taken, and then she was in a room. EKG didn't show anything, and it was only when I actually wasn't thinking of the chemical exposure particularly, but I was asking her, well, if you got chest pain and EKG look okay, maybe this is a viral thing, maybe it's pleuritis, so you have any other symptoms, been having a cold, a sore throat, anything else? She said, well, the throat bothers me a little bit, but my eyes are really stinging. And then it's like, oh, well, maybe something else is going on here. And once we asked what she'd done, she told us that she had taken, which two cleaners do you think she took in order to mix them together and cause an exposure to an irritant? Right, so she got exposed to chlorine gas, but yes. So exactly. So she took bleach, sodium hypochlorite, right? And then she mixed it with an acid, and she liberated chlorine gas. So she was scrubbing while inhaling a war gas, not a good idea, but that's what she did. So, and she did fine with just a little ventilator, a little albuterol. We irrigated her eyes because they were symptomatic. She didn't have any, corneal injury, but she was just mildly symptomatic.
Can I make a comment?
Sure.
We had a case about 2 weeks ago. I was working a shift with Dr. Tharwat Zahran at the American University of Beirut. It was an Ethiopian woman, came in with severe respiratory distress and wheezing. So she required immediately a BiPAP. So there was a language barrier, and now you have a mask barrier, but they could tell from her that she was not asthmatic, Then we found out that she was cleaning. I asked, what were you doing when this happened? When she stabilized a little bit. She was cleaning, but that's not always, so that's not enough, because we said, what were you cleaning with? So she said what she was cleaning. We had to go find out what the ingredients were. So we sent her family member to the supermarket to go get us the product that she was using. It's a famous product in Lebanon called Yes, Tlitib Wahad. You've heard of it? And then the chemicals in there were not also straightforward. It said anionic acid, so it didn't tell us which acid. And the other chemical she was using contained chlorxylenol. Chlorxylenol. So we assumed that she released chlorine by adding an anionic acid with chlorine-containing xylenol compound. So it's not always as simple as bleach.
So either you can look up, the agent, and they call the Poison Center if you have access to look it up on, Google's almost always available. Try and see what the chemical compound, or you can listen to the words, right? And we'll get into a couple examples of that. Chlorine. If chlorine is in the compound, it is likely, not always, but likely to be liberated and then cause a irritant effect.
Fixing a lot of these fixing flash, compound called flash, chlorine.
Flash is a base, right? It's the potassium hydroxide.
Yeah, and they mix it with the chlorine compound. We have seen several women coming, maids, and after mixing it in bathroom, initiates a reaction, and they all come with respiratory.
So I should mention, so we've just talked about, sodium hypochlorite and an acid, right? Sodium hypochlorite and ammonia, that's chloramine gas, which actually in your airways reacts with water, releases chlorine, right? But it also then reacts with the water to make hydrochloric acid. So, right, so at the end, as far as your cells are concerned, you're being exposed to usually an acid, but sometimes a base. And just like with the skin, strong acids and strong bases are not good, in direct mucosal or tissue contact. And to breathe something in that now is doing that right at the cell surface is a good way to cause injury. And I should mention too that hydrochloric acid, right, sounds a lot like hydrofluoric acid, especially if you're communicating over a radio or if there's a lot of excitement going on about a potential exposure. But they're very different. Well, hydrofluoric, as Ziad said, is a very weak acid. It doesn't dissociate much at low concentrations, but it will penetrate deeply to the tissue. Chlorine and chloramine are different compounds, but they act and behave somewhat the same. There are others that we talk about that they just sound similar. So sometimes you can't even depend on the words that are being transmitted because they may not be accurate for what's actually going on. This is a little bit larger exposure, but the same kind of thing. This is somebody who's getting the town pool ready and was now overcome by fumes. Well, getting a town pool ready is an important history to obtain because getting it ready means shocking it to kill off the organisms that have been in it over a period of time. And when this person came in, they have a noticeable odor because chlorine and its related products have a very noticeable odor. And that odor is detectable well before it'll become an irritant. But trouble is the staff are affected because they are seeing how sick the person is, and now they're also experiencing some of the same symptoms, mild, but they're still experiencing them. So you want to not only get the person out of the exposure, but get the exposure away from your staff. So taking off the clothes, doing a limited decontamination in order to remove any remnant is a reasonable thing. And that would be, this fellow. So coming in, he's got enough airway exposure that he's actually got edema at his face and eyes, which of course I've obscured his identity so you can't see his eyes, but airway edema also at the lips and the throat. And you can't actually have people who actually asphyxiate because of upper airway obstruction. And then if they have been trapped in an area long enough, they will continue to breathe in and out, and then you end up with the pulmonary edema pattern that's depicted here. So this can also occur in large-scale events, right? Because chlorine is a major production chemical, and it's used in a lot of industrial processes. So it's shipped by rail, it's shipped by tanker car, and then it's also put into storage vehicles. And this is just actually, if you want to take a look at this, this is the Chemical Safety Board's reenactment of an industrial accident that occurred when somebody delivered a tank car of chlorine and then force fit the connection into the wrong tank and ended up mixing the chlorine with acid. These are just examples of the tankers, and this is what can happen from an explosion. This was I think these were 20, this is either a 20 or a 30-ton release of chlorine that was done with an exercise that was called Jackrabbit to try and look at how these clouds and plumes actually propagated and the effects they'd have. And this is a picture immediately after the release. And this is as the cloud spreads, and you can notice the color. So if people describe the colored cloud, as you were mentioning, to a yellowish cloud, it almost always means chlorine. As with the example of the mustard agent, though it might not only be chlorine if other things are mixed in with it, but that's a chlorine cloud, and you don't want to breathe that in. Even by the time it disperses and the color lightens a little bit, that's still a lethal concentration of chlorine. So you would not want to be out into that. It's actually, they have a monitor measuring an inside of that vehicle, that's the roof that's shown there, and a sheltering place in a vehicle with the windows up and the vents closed is a relatively protective thing, but it's all relative. You can still end up with an injurious concentration if you stay there too long. All right, so water-soluble respiratory irritants usually lead to escape because of the warning properties that you will experience in your upper airway, but it can get to be more serious than that. Treatment is pretty much irrigating the eyes, bronchodilating, but mostly getting people out of that area. And ammonia, chlorine, sulfur dioxide, formaldehyde, and methyl isocyanide, as Ziad was talking about with the Bhopal event earlier in the day. So water-insoluble respiratory irritants, they were also used as chemical warfare agents in World War I, and that's the best example is phosgene. But it's also present in industrial processes and farming as well. So you can end up, I'm sorry, not phosgene, but you can end up with other water-insoluble irritants like the oxides of nitrogen from storage of wet, especially wet grain or silage. If farmers pull it in quickly and then are stirring it up to kind of dry it, the process will lead to oxides of nitrogen. And so those two different chemical compounds will also present somewhat the same way, which is a delayed onset of respiratory symptoms. Again, I guess it's a general rule, you never want to breathe things you can see, and this is a nitrogen dioxide exposure from a fire in the lower picture, and this is actually a Russian. Everybody in Russia has, the dash cam, so you catch a whole. I don't know why that. Well, I do know why that is, but so you catch a whole lot of video there. But this is a truck that was just leaking nitrogen dioxide, and right behind that cloud is an apartment building. But you'll notice in the fire on the left here is people are not, all, running away from the visible cloud because it's not particularly irritating. And that you could see with, say, an old X-ray film repository if that caught fire. And the reason for that is, and it's just a chemical reaction that's shown here, is you do get some hydrolysis to hydrochloric acid from phosgene, but it's very slow, and it's not going to cause warning or development of irritant symptoms unless it's a very, very high concentration exposure. But what happens over a longer period of time is that phosgene reacts to amine groups, which are present in all of your cells in things like DNA and RNA and proteins, and then that covalently binds them and then releases additional hydrochloric acid. So you not only get the dysfunction by your cell molecules being bound together, but you also get additional hydrochloric acid exposure. But because of that, the injury is deep, and it's more slow in onset, and it's characterized by pulmonary edema over a couple of days time. And this just shows one progression and kind of a poor X-ray, but the development of additional infiltrates over hours that were not present earlier on after exposure. So summary for that is just here. Again, bronchodilators sometimes have a role, but mostly it's oxygen supplementation, and steroids probably play a role if you give them early enough, as you would for other inflammatory lung diseases. And just to emphasize, this is the difference between the warning properties for the compounds and their actual toxicity. So the listed number down there, the acute exposure guideline levels, these are determinations that will identify time frames. So this would be like 15 minutes before you would be exposed to a potentially life-threatening dose at these given concentrations. So you can be exposed to 1,000 times more ammonia before it'll harm your lungs than you can for phosgene. But you can't stand to be exposed to that much ammonia because it would be so irritating. So it's very, very noxious, but not as harmful in terms of lower lung injury. But phosgene is not going to give you the warning properties. And that makes it a little problematic because people can get much more injury without being aware. So this is just a quick summary of some of those agents we've talked about. Ammonia methyl isocyanate that Ziad had mentioned with the Bhopal event. And the difference again on this whole list is phosgene is a delayed onset, delayed recognition, insoluble irritant, while all the others are water soluble, more or less water soluble. And then HF, or hydrofluoric acid, has additional systemic properties that Ziad already mentioned that distinguish it from a lot of the others. And then Ziad had wanted me to include, and actually provided many of these slides, some of the issues regarding other irritants that are unfortunately a common source of exposure, a common source of clusters of illness, and those would be the riot control agents. You also mentioned the smoke bomb. So, this would be important for, again, the names of things. So, Ziad, this was a case report you guys had put together with...
this is zinc chloride. And this was a person who was an illegal immigrant in the U.S., was running away from the police, hit in a storm drain, and to smoke him out of the storm drain, the police used this smoke bomb inappropriately. So he went to the ER, coughing and short of breath. They gave his X-ray was negative. They gave him steroids, antibiotics, and took him to jail. Came back within 12 hours in this shape and form. Severe illness, 23 days intubated.
So smoke bombs. Again, the importance of the names of products. Those are usually zinc oxide plus a chlorinated hydrocarbon, so hexachloroethane, right? So a very chlorinated hydrocarbon. Now, so you think, well, the chlorine, then maybe that becomes relevant. Zinc oxide is, you can use that as a protective cream on your skin, right? That's what could be the harm of that. Well, much like we think of For those of you who were here yesterday about the lung injury associated with the cannabinoid vaping products, vitamin E acetate. Vitamin E is also just fine to ingest or put on your skin, but you probably don't want to be inhaling it into your lungs. So zinc oxide as well, you don't want to inhale grease into your lungs, but that's not the major issue here. If you combust zinc oxide and hexachloroethane, hexachloro, now you end up with a chlorine exposure. So you end up with acute lung injury. And the combination is no better because you've now exposed yourself to zinc chloride. And zinc chloride is a very irritating product in a closed space. In an open air, not so bad, but closed space, not so good.
Use it for smoking people out, for drills and for signaling.
Yeah. So to simulate like the fog of war, fog war, that kind of thing, it's different than the riot control agents because it's an obscurant. So it might be use it on the battlefield as an obscurant, but you could also use it. Well, here I guess. Yeah, well, so we prize our actors, so we try not to injure them, I guess. So that's usually something. Usually that's something else. So with you or the stage scenes at where you have the smoke, as it were. That's often, I'm trying to remember. I don't know. Dry ice can be used, so it can be carbon dioxide, which again could be a problem if you had enough of it. But the smoke stuff that's used on stage, I've forgotten what that is. It's usually not. Yeah, not the pyrotechnic smoke, but just the stuff that's done for mood or effect. It can also be irritating in sufficient concentration, and more so at the eyes. And we've had actually people who've gone out to dance parties and then have shown up with injuries to their eyes and skin where they've ended up, especially skin with with water, from tearing or in the creases from contact with that agent. It's all a concentration effect, right? It's still dose. If you do that in the open air, it disperses, not much of a problem. You do that in a small space and people stay there, it can be more of a problem. So riot control agents, tear gas it's not a gas, it's a solid, but it can be aerosolized or made into more dispersible product. And these are just some of them. The ones that we pay most attention to, well, the ones that we end up having most exposure to in our country are the pepper sprays or the Is Ricin capsicum, which is mostly pretty well tolerated. I mean, it's an acute irritant, but it doesn't cause long-term effects. The CN and CS are a little bit more problematic, with CN being more potent than CS, but CS having a potential problem for a delayed onset pulmonary edema if there's been a sufficient exposure. This paper, actually, if you want to pull that, the British Medical Journal from 2009 is a review of a number of these different agents and talks about the time to onset and the duration of persistence or usual. Sometimes that can be a little bit longer, especially if it's in a closed space. So again, the name, right? Chlorobenzylidine malonitrile. Well, that just rolls off the tongue, but chloro, right? So it's got chlorine in it. That's the important part. At the other end of the word is nitrile, and we didn't really talk about this, but nitrile products that's cyanide. That's CN. But this is not a source of cyanide exposure. Right? It is a cyanide molecule in this compound, but it doesn't cause the harm. But you can see that if you just look at the name, people can carry away the wrong message. But when you say, what are people experiencing, then you're going to say, well, they're complaining about their eyes and they can't irritate. It's tear gas. After all, they're all irritated there. They can't see. In their nose and their throat, they're coughing. Maybe if they've got asthma, they're going to end up with more problems because now you've got a reactive airways condition that you've precipitated an exacerbation of. And there are people who are more at risk for some of these effects, as noted here. Contact lenses, that's an important one to remember. And if people have contacts, those need to be taken out, and then the eyes irrigated to prevent any more long-term effects. So the environment, the nature of the exposure is also important in addition to the dose. And management, I mean, is pretty much, if it's been a gas that they're exposed to, they probably don't need much decontamination other than, well, actually no decontamination at all. If it's a vapor, they need to have their clothes removed, the external clothing at least, so that you don't have any trapped in the folds and whatnot that now contribute to secondary contamination. Wet decon is going to be needed for exposed surfaces like the eye, but may not be needed for the whole patient. And supportive care is important. Oh, and I guess we've just finished with this. So you already mentioned that the vesicants can cause pulmonary injury as well as skin and eye. And the best predictor, from my understanding, and we've been contracted to do a little bit of work to try and identify the risk of chronic effects following an acute exposure from a number of these agents, is the degree of symptomatic exposure to the eye and the extent of skin vesicles and blisters if they develop. But that can be so much moderated by the amount of clothing and protective gear that people are wearing. The eyes have become maybe the better predictor. But pulmonary and eye injury, delayed and progressive, especially eye injury, is related basically to what Ziad already mentioned in terms of the damage. So you're initiating damage immediately. But why is it that 15, 20 years later, people are developing significant keratopathy and corneal ulceration and things like that? And some of the reason for that is that some of that initial damage that's occurring is taking out stem cells. And if stem cells are not there to replenish, you're retiring and apoptotic cells as ongoing injury occurs over life, you're going to end up down the road with a less reserve, less ability to manage the daily issues. And those become now long-term effects of the acute exposure. And I think I'll end it with that. Right.
Thank you.
Thank you.
Any questions or comments from the participants before we break for lunch? Dr. Aaron. No, I think it happens with the chemical irritation that happens in the inflammation. You get the pneumothorax, and then he had bilateral pneumothoraces and pneumodiastinum, and he had chest tubes and on the damage, I think, from the chemical damage to the tissues.
Okay, thanks.
Other questions? Masad?
Thank you. Because recently, as everybody knows that...
Can you please speak up?
Yeah. Recently, as we know that there's a lot of demonstrations in some of the countries, and there's a massive use of smoke grenades. So regarding the the tear gas, regarding the toxicology side of these smoke grenades, anything as a physician, as first responders need to be aware about, especially the smoke grenades?
Yeah, so most of those riot control agents delivered by, an explosive or under pressure release, then you end up with, ideally, these are developed and marketed not because they cause permanent injury or death, but because they cause an acute onset. And the table, the CARRON paper from British Medical Journal is a good resource to go to compare them and contrast them. But within seconds onset, but within half an hour offset, right? So short-term irritant effects because they're very water-soluble compounds. But if you now deploy those across a population that includes, and a lot of the demonstrations you described, young children, mothers, the idea that if people go in mass to protest, nobody would hurt them, but maybe that isn't true. But now you're exposing populations that are not young military recruits, that the idea was that's where it's going to be deployed. So you can end up with people who have asthma. Well, they're going to potentially have persistent effects. Or people who just try and run away and hide or go off in a corner and stay in if they especially drop down into an enclosed space, they're going to have a persistent exposure. And persistent exposure to an irritant can cause injury. So I think it's more that, not that the compounds themselves are inherently super toxic, they're not, but you can expose susceptible groups and the circumstances of exposure.
And Dr. Othong, who's actually now in snake inflammation, he taught me one lesson. In his hospital, was very close to the Prime Minister's location in Bangkok when there were demonstrations protesting his, presence in that office. They would come quickly to the emergency department. And before complete hydrolysis, so this is not a gas, it's powder, and it hydrolyzes rapidly. So if you get the victim quickly, or the responder is there quickly with the victim, there may be still ongoing hydrolysis and release of the irritant.
So there's secondary exposure, and we've seen that even with
Pepper spray
is, people will come in, and if they come in quickly enough, and enough of them, you get a little irritated in the room. Right?
So you have to do
pepper sprays are way down here compared to CS and CN.
You have to do wet and dry. So the idea is you have to do dry decontamination is not enough potentially. You have to do wet decontamination, which is lacking in some places.
So while you're doing the wet decon, though, right, they may complain of more symptoms, but that doesn't mean stop. It means you need to do more. Like just if it's kind of like we're often asked on chemicals. Well, aren't there some chemicals you should not, wash with water? And it's like, well, technically yes, right. You should not take phosphorus, or you shouldn't take sodium and lithium as a metal and dab some water on it. But turning a fire hose onto somebody with a little bit of that on it is fine. But if you've been exposed to pounds of this stuff, maybe water shouldn't be used. So it's all a relative thing. Persistence in a given area versus removal of it rapidly.
Yeah.
Dr. Hamoudi.
Yeah, thanks a lot. In my country, many people exposed to this tear agent, many protests. And so many people ask me, my friends, are there any rule for the Pepsi can or baking soda to ameliorate the burning pain sensation? Scientifically speaking, I didn't find...
I don't think so.
So for inhalation of chlorine, sodium bicarbonate added into the nebulizer, if you've got people with persistent airway symptoms for that, there's case report data that suggests it works, and there's no reason to think it would harm people, so that's probably reasonable. Decontamination, if you're talking about things you can mix in with water or add or substitute, the problem there from my perspective is that anything you do that delays application of the water is going to increase the time of exposure. And so even though it might be that some things, like CN, for example, will hydrolyze better if its pH is up, 9 or so. But if you have to go hunt around for stuff and then get a basin from somewhere and then pour the water in and mix it, and it takes 10 minutes to do that, it would have been better just to put a lot of water on them 10 minutes ago. So that's how I'd answer that.
People who are exposed to tear gas in the last events in Iraq, they experienced Pepsi was very effective.
Which one? Pepsi?
So that may be readily available.
That was a standard.
Were they drinking it?
Everybody had a bottle of Pepsi in his pocket. So it was effective, and they immediately washed their faces with it.
In Lebanon, they're using basal, onions.
Well, that's just to get the substance P up there.
And charcoal. Some people have been bringing charcoal to the demonstrations.
Everybody in the United States carries a bottle of water because we're all in imminent danger of dehydration all the time.
Bottle of water is okay, but
But
now
if you have
they
Pepsi-
found out that Pepsi was effective.
I think we're all in imminent danger of hypoglycemia and dehydration right now after a long morning. Thank you for our speakers and participants. Let's have lunch. Come back here to start at 1:15.
Dr. Waxon. But just in case we merge seamlessly, I'll introduce him now. So Paul Wax is the Executive Director of the American College of Medical Toxicology, and he's a medical toxicologist out in Phoenix, and also with UT Southwestern, running the toxicology clinic and practicing there when he's there practically, it seems, every other month. So this is going to focus now on the cluster of neurologic symptoms. And again, we'll try and keep that same format of a broad differential and some of the importance of not only the chemical compounds itself, but some of the other issues that can come up in the differential diagnosis, and then how to sort all those out. So if I could have the slide set.
Chuck, and it's been, again, a great meeting, and I thank Dr. Kazi for all the speaking opportunities that he's provided me as well. Hopefully you're not too tired of hearing me speak at this meeting. It's been a great meeting. I've learned a tremendous amount from everyone here, and you know, the faculty is really to be commended. So we're going to shift gears from inhalational and pulmonary to neurologic, and what we decided to do is Dr. McKay was gracious enough to put together part of this opening talk. So I'll just go over the goals and objectives and turn it over to Chuck for a few of the first slides. But there's a large differential diagnosis when it comes to clusters with neurological complaints. I mean, the brain is so essential to our own being, and many, many things can affect the brain. So we're going to recognize that there are many components to someone that might present with some sort of nervous system perturbation. We're going to divide it into these toxic syndromes, as you'll see, and discuss sedation and convulsions and hallucinations, and go into that in some detail. But before we do that, we're going to discuss briefly radiation syndromes that may affect the brain, and also, very importantly, infectious disease processes that may affect the brain. So with that in mind, why don't we turn to the next slide, and Chuck, you could go over the next few slides if you'd like.
Sure. All right, so somewhat similar to the respiratory issues, although people would necessarily have a lot of concern about a radiation exposure, and people presenting from it because of their concerns about secondary contamination, or just the issues of dealing with a patient who's been exposed to radiation. It is very, very unlikely that anybody who's had a radiation exposure is going to come in with predominant CNS symptoms. And if you think about that, it sort of makes sense the way we think of radiation as interacting with our cells, is that cells that are very, very rapidly dividing, cells that are very active in terms of metabolic processes, are the cells that are more likely to be impacted by radiation. Now, I would hope that most of our brains are active, some of the time anyways, but the sensitivity of the CNS to radiation is not the same as, say, the GI tract or the bone marrow. I know Zia didn't really mention, but the most early measurement for a radiation effect in terms of some of the common tests we might be able to do, do you guys know what that would be? What blood test do we depend on for early evidence of a whole body radiation exposure? So lymphocyte, right? So you're looking for a depletion of the lymphocyte count. And if you think about lymphocytes, they are not an active, I mean, they do divide, but they're not the most actively dividing cell. They actually have a long residence time and circulatory time. But you think also of what the lymphocyte looks like, right? It's a cell that has 90+% of its volume taken up by the nucleus. So it is, with a radiation hit, it is much more likely that that cell is going to be impacted in its nuclear content, and therefore have an impairment in its function, than a cell where the DNA is all tightly wrapped together within the nucleus, and you're more likely to just hit water or something else within a cell. So the lymphocyte is a very early marker. The CNS is a very uncommon organ to be involved. And this table is just a part of the presentation that's up on the Radiation Emergency Medical Management site, like Ziad showed you with the Chemical Hazards Emergency Medical Management. This is something that's housed at the National Library of Medicine, has an a slew of information in it, but it's best to go looking for that before you need it, because it's hard to navigate if you're in a stress circumstance. But they have a lot of charts and a lot of graphics, and one of the things that I just will emphasize here is that, that the likelihood of a CNS component, so this neurologic issues showing up with radiation exposure is not till you're up in the 10 gray or even a little bit likelihood in the 8 gray range, which is a radiation, whole body radiation exposure range that is lethal, uniformly lethal. So if people show up with CNS symptoms, it's because they've had a lethal exposure, and they will be manifesting other evidence of radiation exposure by that point. It was significantly the drop in the lymphocyte count. So it is not something we need to spend a lot of time with. Having said that, people who have had a potential radiation exposure are going to be very upset, nervous, and also they may have all of the sympathomimetic or other kind of features going on that might make them look like they're stimulated or otherwise impaired, because of the issues. So they may have vomiting either because of radiation exposure or because they're very nervous. But vomiting and emotional status doesn't affect your lymphocyte count. So, you still have that to go back to. On the infectious side, of course, it's a lot more complicated. Altered mental status is a hallmark of bad systemic infections, and it doesn't have to be a CNS infection. So, sepsis is going to induce altered mental status. So it's always something to keep in the differential diagnosis, and whenever we're called on people who have altered mental status and some elevated temperature, it's always a consideration, but oftentimes, we were thinking of it when we have patients with, say, serotonin syndrome or neuroleptic malignant syndrome from exposure to some antipsychotic. But again, if you're talking about a cluster, it would be unusual for multiple people to show up with, a simultaneous serotonin syndrome or something like that. So keep it in mind, usually you're going to have a fever and some prodromal symptoms like I was talking about with the respiratory issues, but keep it in mind, it can sometimes be an issue. And one of the ways to rule it out if you're talking about a larger group of people is just comparing, the time, the epidemic curve, as it were, right? A chemical exposure generally causes a lot of symptoms in a large group of people within minutes to hours, and then it tails off over time, with very rare exceptions like Ziad already mentioned earlier this morning, like dioxin or methylmercury, where you have a delayed onset symptom. But for the biologic agents where you have an infectious process, you need to have the latency time for organisms to grow and reproduce, produce their own toxins and cause effects. And so that's going to be days to weeks. And if it's a transmissible illness, that's where you're going to see a weeks-long epidemic curve, not just an hours-long kind of curve. So keep that in mind, and that'll help sort that out. Oh, it really likes that one. So the chemicals, the things to remember here is that, if we say, well, it could be a chemical exposure, that could be true, but how are you going to keep track of, hundreds of thousands of chemicals? And the answer is you can't. But when you're thinking about chemicals that have now exposures that cause CNS issues, and it's a cluster, this becomes a lot more manageable. We hope that it is more manageable, because if, again, you're not likely to have a large number of people exposed to a chemical all at the same time, so that's a medication, unless there's been adulteration of the food supply. And in that setting, the most important thing is to kind of keep it in mind. And if somebody comes in saying, I think I may have been poisoned by something I ate, drank, a medication I took, you have to consider the likelihood, but how likely is that? And one of the mechanisms or processes we use to think about that is the what's called the production distribution bow tie, in terms of looking like two triangles brought up together, evaluation. And if something were affecting, say, a food contamination at the production side, where you have a few ingredients that are put together and then distributed to a large group of people, then you would expect a large number of individuals to be affected. If it's tampering with a product after it's already been placed into the store, for example, then you would a small number of people involved and in a very localized area. Whereas if it's if it's something at production side, it's been distributed to many, many areas, and then you'd expect multiple sites and multiple people. So those kind of things, just kind of bringing it into the realm of what am I going to do and still take some action, helps with that. So if you think about this just in terms of what might happen when you're next on duty, if 5 people are unresponsive at home and paramedics are responding or they're being brought to the emergency department for evaluation, think which one of these things is more likely. They all have serotonin syndrome because they're all on antidepressants and then took some dextromethorphan. Well, sure, I guess maybe it could be, but probably not. Actually, almost for sure not. Fentanyl analogs, well, that could be, right? If they were all using at a drug house, and they all became overcome. That's how we actually recognize a new fentanyl analog being introduced into the heroin supply, because many people are affected all at once. So that's a possibility. But again, if you find out that it's 5 people that are all related to each other and they're multiple generations, and it's a nice home, not a drug-using house, well, then that's less likely. So circumstances, remember, it's not only the toxin, it's also the circumstances and the nature of the patient, the host, those 3 things together. So carbon monoxide, that actually would fit really well. You've got 5 people overcome in a house because of some problem with the exhaust of the heating system or the oil or gas burner, that kind of thing. And we've had this happen repetitively enough so that it's a real concern, public health concern, in terms of keeping people safe by putting carbon monoxide detectors in their house. And the thing to remember is that if you have many people involved like this, is that if you're responding as a paramedic, you do not want to be in that environment for very long. And we've had, unfortunately, people who have tried to resuscitate responsive parties in a home and get overcome themselves because they were in that environment. So just a way of looking at it, and again, the reason to do it is because it allows proper care and protection of staff as well. Well, I think we'll take over now.
Yep. Okay. Yeah. Okay. Can you hear me? I think so. Yes. Good. Great. Okay. Yeah, thanks, Chuck. So as described, the CNS is immensely complex. Billions of neurons, and many things can affect the brain, and we'd like to kind of clump them together to better understand how it affects the brain, and also how we will proceed with the management of a patient or a cluster of patients who have been affected. So one way to look at this is look at the excitation and the inhibitory influences. There's a variety of neurotransmitters. Some of them are more excitatory, others are more inhibitory, and there's a balance between these two. So GABA, for instance, is inhibitory, but glutamate is excitatory. And you take away GABA, you take away glutamate, you add GABA, you add glutamate, and depending on the cocktail, will either lead to more excitation or more inhibition. So there are also other neurotransmitters that may not cause excitation or inhibition, but in some other ways affect the sensorium and modulate the thought processes. And neurotransmitters such as serotonin or acetylcholine are major players in this sort of sense. And in this case, you may get neither inhibition or excitation, but some disorganization or frank hallucinations. And we'll talk more about that in a couple of minutes. So too much inhibition can lead to sedation and coma. Too much stimulation can lead to convulsions. And altered modulation of thoughts may manifest it as hallucinations. So those are kind of the 3 main subtoxidromes under the CNS alteration that we'll discuss with some clinical examples. And we'll start off talking about sedation
and chemicals and drugs to sedate. Now, a prototypical chemical, which may not affect a cluster unless multiple people are drinking, which is not uncommon, is ethanol. And the important thing about ethanol is just to reiterate the idea of dose response. Ethanol is a toxin that it really requires a large amount to cause some sort of alteration. I think I may have briefly mentioned this the other day, but we measure ethanol in grams, and one beverage, one bottle of beer or a glass of wine is approximately 12 grams or 14 grams of ethanol, depending on how you measure it, which is 12 or 14,000 milligrams of ethanol. So it's a lot of ethanol to cause perhaps a little bit of intoxication with one drink. As you drink more, particularly if you drink it all at once, you'll be much more intoxicated, and then to a point of incoordination. And finally, with a large amount, you may have coma and respiratory arrest ultimately. And that usually requires a very large amount of ethanol. But depending on someone's tolerance as well, someone who's not a drinker may succumb to much less ethanol than someone who's a tolerant drinker, and it may require quite a bit more to cause the same effect. So the first example, and I mentioned this earlier this week, I think it was mainly some of the students that I was discussing this with, but what happened in Moscow in October 2002, and I think most of you probably recall this or have learned about this at one point in terms of the effect of some sort of gas on this whole theater. So as you may recall, the Chechen terrorists took over this Moscow theater, and the Russian military wanted to put down this terrorist event, and they attempted, for them was a novel approach, which included the installation of this gas into this theater. And unfortunately, although they were successful in putting down the revolt and killing the terrorists, many of the theater goers were also killed as well, which was not what they were hoping for. And there was much secrecy about what sort of gas this was. Initially, people thought it might be some nerve agent, but nerve agents cause seizures. They generally don't initially manifest themselves as coma, but these people fell asleep and had CNS sedation, and many of them had respiratory depression, and those that died from hypoventilation and respiratory arrest. And as it turns out, it wasn't a nerve agent, it wasn't a benzodiazepine, it was an opioid, but this opioid wasn't given through a needle parenterally or through a pill, it was given as a gas, and that's what kind of surprised everyone, because there wasn't a lot of attention to the fact of using an opioid through a gaseous route of administration. And the gas that it was hidden in much secrecy. It seemed to be some sort of opioid. Folks suggested it was fentanyl, because fentanyl is very potent, but in this case, it actually was one of the fentanyl analogs, which was carfentanil. And carfentanil is an opioid that works just like morphine, but it is much more strong at an equivalent dose. And as you can see in this table that I put together some years ago, one aliquot of morphine is 1/10,000th the potency of carfentanil, which with the same amount is so much more potent. And that's why these people in the US and elsewhere have been dying from fentanyl and fentanyl analogs, because these drugs are just so potent. Now, as it turns out, the carfentanil was initially developed to be used as a veterinary agent, and it was used to sedate very large animals, like elephants, for instance, or bison. And that's how potent it was, because when you're dealing with a 3-ton elephant, you need something that will knock them down without expending a tremendous amount of volume. And that was what was called wild nil, appropriately named the trade name for this carfentanil. So if one came upon a scene and there were a bunch of casualties, people with hypoventilation, with CNS depression, one should think, could this be an opioid? Important to certainly recognize that, because opioids do have a specific antidote, and regardless of the potency of the opioid, if you give the antidote soon enough And if you give at the dose that might be required to block the receptor, you can reverse the intoxication with the opioids. So using naloxone, which is quick on and relatively quick off, is the approach. What happened in the Moscow theater is that the healthcare providers and the first responders weren't informed that the Russian military was using the Carfentanil. So these people came out of the theater, they weren't equipped with the naloxone, they didn't know what they were dealing with, and that's what led to many of these casualties. So how else might we recognize an opioid intoxication? The three cardinal features or CNS depression at high doses, respiratory depression, and then particularly the meiosis that might occur with the eyes. It doesn't occur with all opioids. Some opioids, like meperidine, for instance, there may actually be some mydriasis, but classically with the majority of opioids, you'll see meiosis. Now, you also see meiosis with a nerve agent, part of the part of the cholinergic response from a nerve agent is meiosis. So it's not pathognomonic for an opioid, but someone who has been exposed to some sort of cholinergic agent is going to act very differently than someone who's exposed to an opioid. That's why the initial reports in the Moscow theater that it could have been a nerve agent because they had small pupils, but didn't make any sense. Okay, so that's briefly sedation. Many things cause sedation. We'll use a couple other examples as well, but there is increase in the inhibition, and the naloxone helps to reverse that effect. Other things that are important along with the naloxone for the opioids is supportive care. And if it's a non-opioid where there's no specific reversal agent, then supportive care is the primary management. And supportive care includes respiratory support, and then in cases with hypoventilation, ventilation, and it's critically important and may make a very big difference. Historically, it's of interest that years ago, with a lot of stimulant poisoning, with a lot of barbiturate poisoning, which is a sedative, the thought was the treatment should be to use a stimulant to reverse the effects of the barbiturate overdoses. And the morbidity and mortality from barbiturate overdoses did not decrease despite the use of stimulants. And that was in part because these patients were then developing stimulant poisoning and developing seizures and convulsions and dying from the treatment, while they should have just been given supportive care and ventilation. And one of the major breakthroughs in the history of the treatment of poisoning was the so-called, what they call the Scandinavian Method, which was to abandon the use of the stimulants to treat the sedative patient, and just to support them with airway and ventilation. Okay, so turning our attention then to convulsions, and differentiate between convulsions and seizures. So inhibition of inhibition, if you take away the inhibition, you may then have a seizure. And this occurs pharmacologically in many examples. And there's a whole list of chemicals and drugs, pharmaceuticals that can cause seizures. And this is an example of a case of mass poisoning through this rodenticide, which was used to poison and many people developed seizures. And initially, these first few cases that occurred in the U.S., in fact, one wasn't sure what exactly they were dealing with. But as it turns out, they were dealing with a chemical with the abbreviation of tetramine. And this is a very seizurogenic sort of chemical. And there was this fellow in China that was using this to kill some of his competitors, and led to killing over 38 people in this one event. So tetramine is a very strong poison. It was used as a rodenticide, but banned years ago. But it was still available, and this caused this mass poisoning. This is another case of 61 students felled by this rat poison. One thing I should mention about rat poison particularly is there are lots of different types of rat poison. So rat poison is not one specific chemical or one specific drug. Many of the rat poisons used historically were extremely toxic, like the tetramine, but they included chemicals like arsenic and thallium. And typically nowadays, the rodenticides are somewhat safer. We heard, I think earlier this week perhaps, about the brodifacoum that was used to contaminate the synthetic marijuana in Chicago and elsewhere in the United States. And that's one of the safer rat poisons, but it's a very potent anticoagulant, and if you take enough of it, again, dose response, it can anticoagulate a person as well and lead to significant bleeding. But this is an older rodenticide and causes seizures. So this is a list of some other chemicals that cause seizures, back to the stimulants again, and some of the agents used for nerve agents, which are organophosphates. The nerve agents or the pesticides, and we've heard a lot about that this week, organophosphates and carbamates. At low dose, depending on the chemical, seizures may not be evident, but as the dose increases or if it's a more potent organophosphate, seizures certainly could occur. Same thing with nicotine. Now, of course, nicotine is ubiquitous as a chemical within tobacco. People that use tobacco tend not to seize, but if they use too much nicotine, certainly this can cause seizures, and people have gotten into nicotine. Young children can get into nicotine, or even adults. Nicotine has been used as a pesticide in the past, and if someone deliberately ingests some of the nicotine, that can cause seizures. Hydrazines are also chemicals that cause seizures. Hydrazines we find actually in some types of mushrooms, and also we find hydrazines in rocket fuel, and if someone was exposed to the hydrazines, they can cause seizures. Camphor is an old-fashioned mothball that it tends not to be used anymore, in part because of its toxicity, but is also very seizurogenic, as well as organochlorines and strychnine. Now, strychnine is interesting because from a mechanistic standpoint, strychnine doesn't cause electrical seizures in the brain, but because of its effect on neurotransmission peripherally, patients become very stiff. They seem like they're having seizures, but they're really not seizures per se, but clinically they manifest as similar to someone who was having a seizure. Okay, so what is the management of someone with convulsions? Is to sedate. So before we talk about sedation, the management is not to stimulate, it's to support them, it's to use an antidote if it's a opioid such as naloxone. But with seizures, we don't just support them, we have to control the stimulation, and so sedation is quite important. I think one of the major advances over the last 30 years is the recognition that this is really of critical importance, that one needs to sedate the patient. You can't just put them into physical restraints, but you need to chemically sedate them if they're agitated, or certainly if they're having seizures. So a good first-line approach is the benzodiazepines. It doesn't always work. It works much of the time, but not always. There are other drugs that can be used, such as barbiturates or propofol, which is used in anesthesia. But these chemicals are important to consider, particularly if the benzodiazepines are not initially working, because of the emergent need of controlling the seizures. Again, you can't have someone seize for too long, otherwise they develop complications, mainly hyperthermia and rhabdomyolysis from all the muscle agitation and acute renal failure. So a lot of significant complications if someone's not emergently treated. There's certain circumstances where pyridoxine might be useful. Certain drugs such as isoniazid, which is used in the treatment of tuberculosis, an overdose of isoniazid doesn't immediately respond to benzodiazepines without providing the critical cofactor, which is pyridoxine. Okay, and then finally moving on to drugs that, or chemicals that neither sedate nor cause stimulation, but may manifest as hallucinations or some sort of alteration, such as that. And as mentioned at the outset, there are a lot of different neurotransmitters that come into play here: serotonergic, sympathomimetic, anticholinergic, and even anesthetic. So not one common pathway, but they manifest it as an altered mental status, neither sedated nor stimulated, but more having hallucinations. And some of the drugs that have been abused in the past and even today at present, including drugs that affect serotonin, like LSD, for instance, or the tryptamines. This can cause significant hallucinations where the patient is just not there and is not interacting normally. The military actually used LSD in some experiments back in the 1950s. They thought it might be useful to use in the battle and put down their opponent. A lot of that research was done in secret and as far as we know, wasn't continued after the 50s and 60s. But if there was a number of people who were suddenly hallucinating, one needs to think about something like LSD or similar chemical. And these chemicals are extremely potent. It takes a very, very small amount to cause the hallucinations. We'll just move on to the anticholinergic hallucinations. Now, this is through a different mechanism. We've talked about the effects cholinergically and what happens with a nerve agent poisoning or organophosphate poisoning. Well, if you block the receptor, if you block them, in this case, particularly the muscarinic receptor, you'll develop what is described as an anticholinergic toxidrome. And one of the features of that anticholinergic toxidrome is what would be described as a delirium. These people are often awake, and they just don't interact normally. They talk very funny. It's kind of gibberish. They're making no sense at all. And they can also get somewhat agitated, but they don't even need to be agitated to be very symptomatic, and it can be quite dramatic. We see most of this with pharmaceuticals that have anticholinergic properties, particularly diphenhydramine, but it also occurs in certain plants, Jimson weed, and if there was a mass, if there was a picnic or something and someone inadvertently contaminated the flour with something that contained scopolamine or one of these belladonna alkaloids, there might be a mass outbreak of what would look like anticholinergic poisoning. And this is the mnemonic that we often use to remember the clinical effects of the clinical effects of anticholinergic poisoning. Not only are they delirious, but they tend to be very dry and hot, and they may be unable to void. So there are a number of features of anticholinergic poisoning, but the more severe manifestations are usually the CNS alteration. So this was hundreds of years ago in Jamestown, Virginia, in the U.S., but there was a picnic of some sort, and they accidentally, contaminated the salad with the Jimson weed, and all these people develop what we would consider now to be, anticholinergic poisoning. And this has not only been used historically, but in the Balkans War in the late 90s, these same agents were potentially used, and BZ, which is an abbreviation for a long chemical name, which is not a benzodiazepine, is actually an agent that was developed for military use, and its effect is to cause an anticholinergic syndrome, not necessarily to kill, but to cause this delirium. And you can see the dose of BZ, which is effective, is a very, very small dose. So theoretically, if you had a mass casualty event where there are a number of people acting delirious, one might want to consider BZ. And that was another agent that was considered with the Moscow theater event, but the patients, the theater goers were not acting they were not acting with any sort of delirium. They were all sedated. So it didn't make any sense that it was BZ. So treatment strategy for hallucinations is kind of dependent on the exact agent. If they're agitated at all, one would want to calm them down. Benzodiazepines would be a good first-line approach. If one knew that they were dealing with an anticholinergic agent, antimuscarinic, if you use something that will overcome the receptor blockade, that may resolve the delirium very quickly and efficiently. And we often will use physostigmine. So physostigmine is a carbamate, so it's related to the pesticides. It's related to the carbamate pesticides, and in fact, it is a carbamate. And by blocking the acetylcholinesterase, it leads to an accumulation of acetylcholine, and the acetylcholine accumulation then can help with overcoming the muscarinic blockade. So if the patient is truly anticholinergic, and you have to be careful about this, because if they're not anticholinergic, then you'll make them cholinergic, which is not what you want to do. But if they're truly anticholinergic, a small dose, 1 to 2 milligrams of physostigmine, may totally reverse the toxicity, while Benadryl, it's not working. Okay. So again, the dose for physostigmine is approximately 1 to 2 milligrams. We reserve it when we're fairly sure that it's an anticholinergic poisoning. And if it is an anticholinergic poisoning, and if they are agitated and hallucinating, the judicial use of physostigmine may very rapidly, within 3 to 4 minutes, reverse the delirium. So concluding thoughts here, that the CNS is a unique target organ. There's a lot of different presentations as just described, and the management generally is symptomatic. There's a selective use of certain antidotes, particularly naloxone, if it's an opioid poisoning, and perhaps physostigmine if it's an anticholinergic poisoning. I think I'll end on that note and open it up for questions. Thank you. Any questions?
Let me go ahead and introduce the next section. Pierre has put together a group of speakers for what he's called the special topics area. Just some issues that for a cluster of illnesses presenting over time, other things that may not fit ideally within some of our organ system approach that we've used up until this point today. And so first we'll have Dr. Bruno Megabane come to the podium, and he will be talking about Ricin. I think we have Dr. Megabane's presentation coming to us from Paris, France, and I think both of these are. Okay. And who's going to talk on Ricin?
Ricin, yes. So good morning, everybody. I'm very pleased to be here with you, and we'll talk about Ricin in a few minutes. So the story started in 1978, and you know that the first person to have been poisoned with ricin, or supposed to have been poisoned with ricin, is Markov, a BBC journalist, but from Bulgarian origin, and he was stabbed in the thigh with an umbrella while waiting for the bus at Waterloo Bridge in London, and he died a few days later from a multisystemic organ failure. And on his autopsy, it was found a metallic pellet of platinum iridium, and it was presumed to contain ricin. Then, a few years later, in Iraq, the old regime, the previous regime of Saddam Hussein was accused to have prepared liters of concentrated weapons-grade aerosolized ricin made in Iraq, ready to be used. I don't know if they really existed or not, I don't know, but it was supposed to be. And of course, there was many incidents involving ricin, and if you go to Wikipedia, you see that there was at least 26 different events during the history where ricin was supposed to have been involved. And the most recent episode in Europe was in Germany in 2018, where an Islamic terrorist bought 1,000 grains of ricin and used instructions he received from the extremist Islamic State group and was preparing a bomb, but hopefully he was stopped before using this bomb. So ricin is a bioterrorism agent. It's, of course, a biological toxins, and you see that bioterrorism has include not only bacterial, but also viral and biological toxins, like botulinum toxins and ricin. Ricin is classified by CDC in the B category. That means that it is moderately easy to spread. It is responsible for moderate illnesses with a relatively low death risk. But when you look at the dangerousness of the different biological toxicants based on their median lethal dose in mice, you see that ricin is well positioned. Probably the most toxic toxin is botulism toxin A, and more recently botulism toxin G, which is much more toxic too. Ricin is toxic mainly if it is inhaled or injected, while if it is taken by oral route, it is less dangerous than cyanide. So it is still dangerous, but less than cyanide. What is ricin? Ricin is a component of the seed from Ricinus communis, and it is found in the castor oil, which comes from this plant. It is produced in the world with 1.3 million tons per year to produce lubricants, cosmetics, and even pharmaceuticals. It has been, for instance, experimented to treat pain and prevent graft versus host disease, and also as cancer chemotherapeutic agent. So it is easy to find. Its toxic properties were identified in the last part of the 19th century by this German scientist Stillmark. And now, of course, its mechanism of action is more known. And you see that ricin is a lectin with two glycopeptides bound with a sulfide bridge. And one part, the subunit A, allows the ricin to link to the membrane, while the second subunit can go through the cell till the endothelium, the reticulum, sorry, and then it will inhibit in the cytosol the ribosome activity. So it is glucosidase, and it inactivates the ribosome subunit by modifying an adenosine, by removing an adenosine in the RNA ribosomal 28S. And then the protein production will stop and the cell will die. So that is the mechanism of action. So there are three routes of exposure to ricin. The first one, which is not so rare, it is the ingestion of castor beans, generally for a suicidal attempt. So symptoms occurs about within 4 to 6 hours after the ingestion, up to 24 hours. Normally, the seeds are relatively bitter, but to have toxicity, you have to masticate. So it is not so easy to masticate the seed. And it is estimated if you masticate the seed, then 3 seeds are enough to kill a child and 8 to 20 to kill an adult. So the toxicity has 2 phases. In the first phase, you will have irritation of the oropharyngeal mucosa, rarely more severe corrosive lesions, and then colicky pain in the abdomen with vomiting and important diarrhea. In the second phase, you will develop fluid losses, dehydration, hypotension, electrolyte imbalances that may lead you to hypovolemic shock and multi-organ failure, mainly acute renal failure. There may be also a risk of hemolysis, seizures, cardiac arrhythmias, and in case of fatality, patients will present diffuse intestinal hemorrhage. But this is relatively rare. In case of injection, which is more rare, but still possible, then you will have more severe features, initially non-specific, like fever, headaches, abdominal pain, and then rapidly hypotension with intravascular hemolysis, acute tubular necrosis, and of course multi-organ failure leading to death. You may have also local tissue damage, and death is relatively rapid within 2 days, like it occurs with the Bulgarian journalist. And finally, exposure after airborne, intoxication after airborne exposure. So this is a very rare situation. There is no case report with airborne exposure, but it is supposed to be the way by which ricin could be used as weapon, as bioterrorism weapon. So symptoms will occur rapidly within 4 to 6 hours, and it started by cough, dyspnea, arthralgia, fever, then rapidly respiratory distress, multi-organ failure, and death. The patients will develop profuse sweating, and then he will have pulmonary edema, necrosis, bleeding, tracheobronchitis, and of course interstitial pneumonia leading to the death. It has been estimated that possibly a few people were contaminated by ricin by this route in Soviet Union in a factory that was supposed to produce ricin in the 50s, but there's no case report. So all the data coming from this route of exposure are only in rodents, and by extension it is supposed to be like that in humans. So when you look at the review of all ricin poisoning reported in the literature, and this is an interesting study, so it is like 1 century of cases. You have, you see a total number of cases of about 875 cases. Most of them are accidental and by oral route, but there are some intended cases and some cases by injection. And you see that in the majority, the accidental oral cases are benign without death, while almost all the fatalities occur if the patient inject the ricin, and mainly in a voluntary situation to suicide. Diagnosis is difficult because, as you understood, there is no specific manifestations. Generally, the patient will come with cardiovascular failure and hypovolemic shock, or multi-organ failure. So it's difficult to diagnose if the history is not clear. It is difficult to diagnose ricin poisoning. But if you suspect the diagnosis, then you have several methods of diagnosis. The immunological methods, they are very sensitive. They are relatively rapid. They could be used as multiplexing methods. They are fast and they allow fast and on-site detection. There are spectrometric identification that are with more limited sensitivity. They are relatively rapid in 8 hours. Also could be multiplexing, but they are much more specific. And finally, you have the functional methods. That means that you have to assess the ability of ricin to depurinate ribosomes. So it's a real-time cytotoxicity assay. It's sensitive and specific, and it is mandatory to determine the biological threat level of a sample. So normally, you have to combine an immunologic or spectrometric test with a functional method. Because as you understood, ricin could be present everywhere. So you need absolutely to show that you have a functional positive method. But all these methods are not available routinely and only in very specific laboratory. For instance, in France, only in 2 or 3 laboratories in the whole France. So you can use surrogate methods. And this is the case of ricinin. It is not ricin, ricinin, which is another compound of, that is present in the seeds. It is an alkaloid found exclusively in these seeds, but it is by itself not toxic, of course. So it can be present in different castor oils, cosmetics, and medical products. So if you use this test, you may have some false positive. And of course, you can also find some false negative if the toxicant was synthetic ricin and not castor seeds. So its use is still questionable, of course, but it is easier to use and it is available in more laboratories, possibly in MENA region, I don't know. So what are the management of these patients? First, of course, in case of severity, the patient should be admitted to the ICU. And this is the case following an exposure by ingestion or inhalation in the presence of severe diarrhea, cardiovascular shock, respiratory distress, hypoxemia, massive hemolysis, and of course, organ failure. The patient have to be transferred to the ICU. Treatment is based on decontamination, and of course, if the patient ingested the seeds, you have to use activated charcoal, as usually recommended. There's no specific recommendations here, and you understood that normally by oral route it is not dangerous. No role for cathartics and whole bowel irrigation. Then, of course, in case of symptoms, you have to provide supportive care based on fluid resuscitation, vasopressor supports, oxygenation, mechanical ventilation in case of pulmonary edema, and of course, hemodialysis in case of acute renal failure. Are there specific therapies? To date, there is no available antidote for ricin toxicity. However, some treatments have been suggested to be active on ricin. Sorry. No, it has this one. Okay. So, N-acetylcysteine and liposome encapsulated N-acetylcysteine showed promising results in rodent models. Milk, lactose, and galactose seems also to inhibit ricin B subunit to bind to the cell. So these are experimental in vitro studies. Dexamethasone and vitamin E seems also to have shown some extensive survival in experimental studies. But of course, none of these therapy is systematically recommended in humans. Are there specific therapies that could be more effective? Possibly. There are, of course, antibodies. These have been used in animal studies and have demonstrated the possibility of protection against inhalation and parenteral administration of ricin. There are several methodologies of administration. Passive immunization, and this is These methods show a protection before exposure to ricin using humanized animal-derived FIB and recombinant antidotes. And of course, much more interesting, active immunization by inducing adequate levels of ricin neutralizing protective antibodies. This could be useful as a vaccine therapy in people like military at risk of ricin exposure. There are also non-antibody small molecules that could be effective to inhibit protein-mediated effects of ricin, but to date, all these therapies exist only in mice and rats, nothing in humans, of course. What to do in humans? Of course, rapidly, you have to use the adequate personal protective equipment on the scene. Normally, you should use level A, especially if there is a risk of contamination by respiratory route. So you have to protect your skin, your respiration, and you have to use a breathing system. You have also rapidly to decontaminate the environment and to decontaminate the dermal surfaces of any patient by removing the contaminated clothing and by washing the skin with soap, with water, and of course putting the clothes in a double bag that is labeled as contaminated. And you have to clean all the surfaces and clothing with a solution of sodium hypochlorite for at least 30 minutes. That will inactivate ricin. So in conclusion of this presentation, you understood that there are development in biotechnology that allows to date probably the obtention of ricin easily from the seeds, but also by synthetic production in a laboratory by a possible terrorist state or organization. So these create very aggressive bioweapons. And to date, some states or terrorist groups are accused to try to obtain such biological weapons, despite prohibition. Ricin is active in the absence of any producing organism. It is highly toxic at extremely limited doses, and it represents a challenge for clinical diagnosis and detection. Immediate identification is recommended to contain any further dissemination. And of course, as you see, the treatments are still difficult. That's why WHO is urging all the countries to strengthen preparedness plans to prevent such contaminations. Thank you. I don't know if there are any questions about ricin. Of course, all our experiences are limited in the field, but recently in Europe, following the production of a possible bomb in Germany, ricin become on the top of the issues, and the states and the governments try to reactivate all the specific diagnostic means, laboratories, possible therapies to fight against this possible risk. But to my opinion, it remains limited risk.
Bruno, you'd mentioned the difference between the castor beans themselves and then the ricin isolated from that as a water-soluble product. Most of what we've had in the U.S. has been people who have obtained castor beans and then ground them up or sometimes ingested them whole, which often they're asymptomatic. But we've had events in Las Vegas and a few scattered events elsewhere where people individually have done preparations either in their home or in hotel rooms. And it has raised a question about the level of response, often after the fact, because sometimes people aren't told immediately what's happened, and then after the fact, somebody goes in to try and clean up the site. Do you have any comments on that other than the general recommendations as far as if people have disrupted the shell in terms of responding to those events?
My experience is limited, of course, but normally you see you need a big amount of seeds to extract the ricin from them. Then it is not so easy to produce an aerosolized bomb. Possibly, and that was the case in the US, they put it in envelopes, or they put it on doors or on the shoes of people that they want to be assassinated. But so they suppose that the person will contaminate himself because it doesn't cross the skin, so by oral contamination, thinking that the ricin is sufficiently concentrated to allow this. Because if you swallow a seed without mastication, you have no toxicity. So I don't know really if these means are effective to go to allow a fatality, because it's more frightening, I think. And in many such situations, such people use this ricin to frighten the people. I'm not sure that this really results in a fatality. The only way is to inject or to inhale. And as explained, if you use the seed to have the ricin, then the ricinin is present, and you can use ricinin as a diagnostic tool. But if you use synthetic ricin, but this is only performed by a state, not by a private person, then ricinin is not useful tool. So you have to measure the ricin directly. And you need, in both cases, an analytical or immunological test and a functional test. Because, as you understood, if you use only an analytical or immunological test, they may be false positive, because ricin or ricinin could be found in different situations in a market. So there is a study that tested for ricinin, and about 2% were falsely positive. So you need a functional test also.
Thank you. Any other questions?
Okay, thank you very much.
Good afternoon. I'd like to thank again the Scientific Committee for inviting me here. My name is Robert Hoffman. I'm a pediatric emergency physician and a medical toxicologist. I'm the medical director of the Cutter Poison Center. I'm going to discuss a topic that there's a high chance, if you're a toxicologist or an emergency physician, you might have seen some of this information previously. Some of these slides are actually slides that I just presented here at this conference. So if you attended the previous lecture, you'll see some similarity. I don't have any conflicts of interest to disclose. I will disclose that some of these slides are actually from a World Health Organization template that I've used before, and that's widely used to discuss the same topic. So some of these slides are not my original slides. They're actually WHO slides that are freely available for people to use, and I've used in training previously. But basically, I'm going to discuss some unique aspects of anatomy, physiology, and development, as well as behavior that poses some specific issues with regards to children in RIMIC situations. And then a few specific details of exposures that are unique, and then discuss how this relates to pediatric cluster illnesses, or how it would impact our management in pediatric cluster illnesses. So this is these are just some older paintings, and the reason it's included in these slides is if you look at the older one from the 1300s, you see that the child is actually just a miniature adult, and the exact purpose of this discussion is to explain why that's actually not the case. So kids are not just miniature versions of us. There's significant differences. So So some of the differences relate to exposures. So there are different pathways of exposure. So some pathways of exposure are actually, antenatal. So antenatal or postnatal. So transplacental as well as breastfeeding. More likely to occur on a larger scale is our children's behaviors. So exploratory behaviors, hand-to-mouth behavior, putting things in their mouth that aren't food items or aren't made to be ingested. Their location, their physical location, meaning being on the ground, so either crawling on the ground or just being closer to the ground, even if standing. Higher surface area, so relative to us, surface area to volume ratio. And then kids are preambulatory, and most kids who are going to be exposed to something, including in the US, if they're not pre-verbal, they're poorly verbal. So if you think of kids who are 4 years old or less, they have very limited ability to speak or give their own history. And then if it has to do with adolescence, high-risk behaviors or kind of behaviors that might result in exposure or dangerous exposure that could have been avoidable. So I have a few slides about breathing, because this is one of the key things that differentiates younger children from adults. So I won't go through all of them in detail, just try to give you the specific point, which is minute ventilation. So children's uptake of toxins is faster, and that's kind of specifically related to their position close to the ground and minute ventilation. So this is actually from a pretty cool study that was exposure to chlorpyrifos, so chlorpyrifos sprayed on carpeted floors and toys, and the uptake by children, and you kind of see the peak the peak is kind of right there in the center, as opposed to older children or 10 to 25-year-old patients had very little uptake of chlorpyrifos. This slide is a size and surface area slide, so relates to what I just mentioned. So smaller children, especially a baby, has a very different volume to surface area ratio than adults. This is more significant when it comes to dermal exposures, but it is one of the key things that we consider when we consider pediatric exposures in poisonings or mass casualty situations. So one thing about children has to do with behavioral differences. So younger children either can't recognize danger, or maybe older children, like an adolescent, recognizes but ignores something as dangerous. And I won't read through all of these, but younger children can't specifically remove themselves from a dangerous situation, and actually won't necessarily know that a situation is dangerous. And like I said, adolescents have a risk-taking behavior. So, so xenobiotics are handled differently by younger kids as opposed to older. And again, I won't read through the slide, but just there are some significant differences when it comes to both uptake, metabolism of poisons, and then excretion of poisons. So minute ventilation, which I mentioned before, is significantly different. So the younger the patient, so the closer to infancy, the much higher the minute ventilation. And an analogy to this would be, you've heard the term canary in a coal mine. So, an infant literally is like a canary in a coal mine if you were thinking about something like CO or a toxin that's going to be taken up specifically by the respiratory route. Some other considerations have to do with in-hospital care, staffing, and resources. Lack of pediatric EM specialists is pretty universal throughout the world. It's not common that a child would reach an emergency center in most countries and actually encounter a specifically pediatric EM physician. They're typically going to be seen by a pediatrician, general practitioner, or maybe an EM physician. And there's a little bit of a difference in each of them. There's maybe some advantage and some disadvantage to each, but there's some distinct differences in what they're capable of providing for the child. The other kind of specific issue faced is when children do get to a hospital, it's not really, there's no guarantee that hospital actually has specialized services that are able to care for critically ill children. Meaning it's very possible that the hospital doesn't have a dedicated PICU or neonatal ICU. And besides being able to manage those as inpatients, it might not have other things that are necessary, which might be people able to do ECMO for children, or respiratory services able to keep children ventilated. This is from my talk yesterday. Even some simple things like just supplies. So the reason I showed that blue top tube, it's not specific to a REMIC situation, but it's that blue top tube is, you'll recognize that's an adult vacutainer tube used to check coagulation profile. So to fill that, and it's necessary to fill that tube to a specific volume to ensure the anticoagulant inside is exactly the right amount. Now, the difficulty with these tubes comes in, it's very possible if you have a young child, an infant or neonate, you won't be able to get enough blood to fill that tube, and resulting in a lab error. So there are a lot of simple things that you would think are simple, but actually can become problematic when we're managing children in these situations. Another consideration has to do with developmental or cognitive capability of the child. So typically, children have to remain with the caregiver. So if you're talking about or considering a mass casualty event, you actually have to consider, so are children going to be transported without an adult? And then if decontamination is needed, who's actually going to take a child who's alone through their wash, through the decon? And then, further considerations would be, well, if there's an adult there who wasn't exposed, but they could go with the child, does the adult go through the decon and potentially get contaminated? So there are really a lot of kind of developmental or cognitive questions that come up when managing kids. Once the patient's inside the hospital, we face the same thing. Who's actually going to stay with the patient? It's not really feasible to have a one-to-one nurse for every unaccompanied child. And then other issues of consent, capability of consenting to procedures, consent to a hospital to a level that provides higher care. Specifically, it's issues come up with regard to antidotes. And it's mostly not availability of antidotes, more familiarity or unfamiliarity with antidotes. So for any given poisoning, it's likely that an ICU relative to a PICU probably has more experience applying that antidote. So anyway, this is the second of the pictures that I just showed you, and this is a more realistic picture of a child, which is, a child is kind of like an adult, but a distinctly different entity. That's actually the last slide I have. Happy to take questions. Thank you.
Hello, everyone. I hope you are still awake. So I've been asked to give a talk about paralytic syndromes related basically to toxins exposure in general. And so I'm going to talk in brief, basically. I'm not going to burden you with all of the information related to all of this, but we are going to speak a little bit about Guillain-Barré syndrome, the barium toxicity, botulism, and we had quite extensive talk about botulism in the last workshop. Tetanus toxin, tick paralysis, saxitoxin, and then tetrodotoxin, because we had an outbreak of tetrodotoxin. I would like to share that with you, and then cons if we have time. So Guillain-Barré syndrome is basically the most common cause of an acute generalized paralysis that we see in the emergency department. It's usually commonly missed diagnosis because most of the time we don't know what's going on with the patient initially. And it is associated with significant morbidity. And it's basically happened due to inflammatory peripheral neuropathy, which could be related to virus-induced, bacterial-induced, or toxins. There are four main phases for this disease. They usually start with the interval of an infectious prodrome that happens initially, and patients usually does not know that they are going to develop, or there are no signs of symptoms that they are going to develop this kind of paralysis. But then eventually they progress into weakness, which manifests as symmetrical limb weakness, diminished or absent tendon reflexes, and then, but they have a minimal loss of sensation despite the paresthesia. So that's one of the things that you might put in your mind when you are looking at the differential diagnosis. And these symptoms usually last for about 4 weeks or so. And then they have the plateau phase, and then after that, the recovery phase. The main challenge in this is the clinical diagnosis. So if you have a high suspicions of Guillain-Barré syndrome, you will be able to pick this as early as they come in the initial presentation. But they might have also abnormal nerve conduction study in the assessment. And when you do a CSF analysis, you will find a high protein analysis and a low WBC. And the treatment most of the time is supportive. You can use immunoglobulin, and that's with a high efficacy, especially if it's administered within the first 2 weeks of starting the symptoms. And there have been trials of using plasma exchange as well in such cases. Barium toxicity. So barium basically used as a pesticide or insecticide. The feature of the barium makes it a little bit you know, it looks like a powder, a white powder, like a flour. And then most of the time, people might miss this with the usual flour, and that ends up by an unintentional poisoning. The barium by itself, it can cause competitive blockade of the potassium rectifier channels. So it will decrease the potassium efflux out of the cell. So most of the time, the potassium will be built inside the cell, and there is a decrease in the level extracellularly. And this will cause an increase in the vascular resistance, leading initially to hypertension, and reduce the blood flow, leading to metabolic acidosis. It also indirectly affects the potassium by increase the membrane permeability to the sodium, and so increase the sodium-potassium bond activity, leading to the further influx of the potassium inside the cell, and so decreasing the potassium level extracellularly. And usually, the hallmark of diagnosing barium toxicity is the hypokalemia associated with it, which will lead into overall result, cellular depolarization and paralysis. And that's the main reason behind the paralysis, is because of the hypokalemia rather than the direct effect of the toxin. The clinical presentation, it can cause fixed proximal weakness, also abdominal pain, nausea and vomiting. The hypokalemia can lead into ventricular dysrhythmias, and then death may be related to it, associated with hypotension. And the main thing is that they develop a flaccid muscle weakness and respiratory failure as well, which can also lead to the death in such cases. Diagnosis is clinical, and also there are some centers that they can do the blood level or urine level of barium. The treatment is mainly supportive with aggressive correction of the hypokalemia and mechanical ventilation for the respiratory failure. There are evidence that enhanced elimination like hemodialysis and CFFH might help in such cases. Botulism toxin, again, we spoke about this earlier. Botulism is quite a nasty toxin that, if happened, it can cause great fatality. It's the most lethal toxin known. You need only a small dose of this, like a human oral lethal dose will be 1 microgram per kg, which is quite, scary. The mechanism of toxicity, probably you know this, it's usually, we need acetylcholine in the neuromuscular receptor agent. So what will happen is that you have at the nerve or at the neuromuscular junction vesicles that contain the acetylcholine, and then you have proteins. I don't know if this will show, but you have proteins at the end here. That protein here. Neurotransmitter. What will happen is with the botulism, they are going to affect the protein there, Okay, so that will end up by having the vesicles flowing up there without reaching, the acetylcholine will not be released. And that will end up basically by decreased level of acetylcholine and causing paralysis. So clinically, they will have a decreased symmetric paralysis, descending symmetrical paralysis. They will have normal sensation, and that might be a clue to diagnose botulism, normal reflexes compared to the previous two, and they might have early cranial nerve palsy or cranial nerve involvements. And eventually, the cause of death is basically because of the respiratory compromise and respiratory failure. Diagnosis, we talk about this, but toxins are detected in the serum, stool, and the food. And also, you can grow the bacteria by itself in the stool or in the stool culture. And the treatment is mainly supportive. You can use botulism antitoxin if you have it, and that will shorten the duration of the illness and the morbidity as well. Or you can use also IV botulism immunoglobulin. Tetanus is another cause for paralysis. Tetanus by itself, it's an extremely potent neurotoxin that produced by the Clostridium tetani in an anaerobic conditions. And usually it presents with an acute onset of hypertonia, painful muscular contractions. So you can see that, the classic posture of such patients, and it can cause generalized muscle spasm and increase reflexes. The diagnosis is mainly clinical, and the treatment is supportive. Using the tetanus immunoglobulin might, shorten the duration of the illness as well. And of course, the main thing is the prevention with vaccination. Tick paralysis, again, it's basically peripheral nerve effect due to the one kind of ticks called Dimacentor tick species, and these are basically cause ascending symmetrical paralysis, ptosis, again, normal sensation, and respiratory failure leading to death. Mainly the diagnosis is by identifying that these symptoms related to the tick. You need to look for it and try to remove it. And of course, there are certain techniques that you need to apply in order to remove this tick. And usually the other investigations are within normal, including the CSF. The treatment is by tick removal and supportive care until the effect is completely resolved. Saxitoxin is a paralytic shellfish poisoning, and is basically formed by the dinoflagellates in the shellfish. It can cause ascending symmetrical paralysis. So you can see is almost all of them, they can give you a similar clinical picture, which might, a highly suspicion of